let's get to that, how we actually treat these patients. So Mary Frances, I'd like you to walk us through that. What are the goals of therapy in PV? And how do you select patients for phlebotomy, low-dose aspirin therapy, and those who need cytoreductive therapy?
Okay, so the goals of therapy, well, of course, the goal of therapy that everybody would want is cure or a removal of the disease or the acquired clone, but we don't have that, and we'll talk about that in other contexts later on. So there are two things that we're particularly looking at in a patient we're treating. Then there are particular blood count levels to which we aim for, in particular hematocrit less than 45 or 0.45, and possibly reduction of the platelets and white cells with therapy. The other thing that we need to think about is symptoms. The patients, as Robin has alluded to, have a lot of symptoms, and these are major in some of these patients. And can we give therapy which will actually control or improve the symptoms? The other thing we would like to think of would be if we could prevent progression either to myelofibrosis or to acute leukemia. But again, those are the things we would like to do if we had the tools available for us. So on a practical point of view, when we put patients on therapy, we're looking at control of the blood counts and hopefully improvement in their symptoms.
Well, you brought up a lot of issues there to discuss. One of them is anything that might be a disease-modifying agent. And you know, Moshe, who's with us today, did pioneering work with interferon in chronic myeloid leukemia, and John has been involved in some of the studies of interferon in Polycythemia Vera. And one of the reasons why people have been proponents of it is maybe it's a disease-modifying agent. We've seen decreases in JAK2 allele burden. Why don't you tell us more about what we know?
Yeah, so as Moshe can tell you, interferon is obviously a therapy that's been used in MPNs for quite some time. It's not novel per se. And we believe it has an anti-clonal, anti-hematopoietic stem cell effect through multiple different mechanisms that are probably not well understood, actually. But the reality is interferon in different formulations, but more likely in pegylated formulation, a more tolerable form that's given less frequently, is a therapy that we employ. And it's regionally, I think, depends on where in the world you practice, even where in the world, where in the country you practice. We've done studies evaluating pegylated interferon alpha 2A, which is Pegasus, in patients with treatment-naive, high-risk polycythemia vera and essential thrombocythemia. This was a phase 3 study done through the MPDRC, which Mary Frances was involved with right from the beginning, as well as Robin and many other investigators throughout the world. And this was randomizing almost 175 patients with high-risk disease to either Pegasus versus hydroxyurea. And these are treatment-naive patients who've had the disease for less than 5 years of time. And if you look at the data, one has to really understand the nuances of the data. So at 1 year, the CR rate is really not statistically different. So CR rate meaning normalization of the counts, the spleen, and the symptom burden. It's pretty much the same between hydroxyurea and interferon. It's really after 2 years or so of therapy. It's chronic therapy with interferon. We're using doses of 45 micrograms weekly and titrated up slowly with Pegasus. Trying to balance the toxicity with the efficacy. It's really not until 2 or 3 years that you start to see a change in outcomes. You start to see more, more responses with Pegasus and perhaps more drop-off with hydroxyurea. That's probably best demonstrated in the Ro-Peg interferon studies that were run, which is really interferon alpha 2B and a monopegylated form of the drug called the PROUD-PV and the continuation PV study, in which that was more of a European study that randomized the patients between this formulation of interferon versus best available therapy, which was basically hydroxyurea. And what they saw was it really wasn't until 2 and 3 years that you really saw a divergence in the CR curves. You saw reductions in JAK2 V617F allele burden as a surrogate for disease course modification, although I'm the first one to say we don't really have data that confirms that actually associates with longer survival or less disease progression. It's sort of intuitive that it would and presumed. So if people embark with interferon, which I think is reasonable for patients who are younger in age, particularly with a more longer arching theme of trying to control their disease. It's a drug that can control white counts, red counts, platelets. You have to balance against some of the symptomatology with the disease and the adverse effects of the drug, but it would be a long-term effect in which one can follow serial allele burden for JAK2 or CALR if it's an ET patient.
So one of the problems with interferon is that you need the observer, the investigator, to live a very long life in order to conclude a study, because you may need to do studies that stretch over 20, 30 years in order to have definitive answers, and we may not be able to get it. I'll give you an anecdotal case.
I'm happy that's happened for you, Moshe. Though.
Well, I don't know.
Yes.
I studied it in 1980. It's a long time ago. But I'll give you an anecdotal case. A patient that I started with essential thrombocythemia, but JAK2 positivity. I started to treat her in the late 80s. And she developed a complete molecular response after 25 years. So it tells you, and she's still in remission now, 30 years on therapy. And she still gets it on and off. So in other words, it is very difficult studies to do. There is unique biologic activity to interferon, but to really figure it out and sort it out, we need to design studies that stretch over very long periods, because at least the reports on short-term follow-up, there is no difference in survival between hydroxyurea and interferon. But that's not the purpose. The purpose is very long-term follow-up.
So, so that brings up an issue about, this drug. It's not FDA approved, though, for PV.
No, so interferon, as you know, is approved for hepatitis. In Europe, actually, Ropeg interferon now is approved for polycythemia vera based on this data from the continuation PV study and the longer-term follow-up. It is now with the FDA, actually, for review actively.
Okay, but that would be helpful, because it is a barrier for some of my patients.
I think it would give patients an access to an old but biologic drug that has activity. I would like to think that as we move into 2020, we're going to continue to move ahead and progress in terms of translating science into new drugs.
So let me add one more point on interferon. As you say, John, to a large extent restricted to patients under 50. Although it's an arbitrary number, I am concerned with the effect on the brain, especially development of dementia and depression in older age, and I'm avoiding older age from the uses of interferon unless the patient insists on getting it, and it happens. But overall, I restrict it, and I think it's a good to very good option for young individuals in their 20s and early 30s.
Yeah, I think the neuropsychiatric complications that are sometimes underappreciated and under watched have to really be carefully watched, because patients can develop anxiety, depression, and even almost like a dementia syndrome if not monitored carefully.